I'm really excited about our speaker today and the topic of our didactic. Carolyn Parsey is a neuropsychologist at the Memory and Brain Wellness Clinic here at Harborview, and she is also involved in what she's going to present today. That she's part of the Dementia Action Collaborative, and they've been disseminating a lot of fantastic information to help providers, caregivers, patients, communities really work to improve the lives of people with dementia in our state. So I'm really excited for you to talk us through all of this. Thanks so much.
Good afternoon, everybody. So today I'll be talking. I want to give you kind of a crash course in a lot of the tools and available resources that we have through the Dementia Action Collaborative, which are all available online, and I'll talk more about that later specifically. So today I'll be using Slideout Polling. If this does not work, that's okay. I'll just work by show of hands. Will also be an option. But if you go to slido.com and then it'll have this little box that says enter event code Y431 and then hit join. You, when I come up with a question, should push it out to your phone if you're put in the right code, and you can respond directly from your phone. You don't need to make a login or anything like that. So today I'm going to start off by giving you a little bit of information about early diagnosis and some of the tools that the Dementia Action Collaborative has developed to help primary care providers, geriatricians, nurse practitioners, anybody who's working in any capacity with older adults. So I wanted to give you a little bit of information about what those are and what's available to you. And then I wanted to spend more time actually talking about discussing dementia diagnosis with patients and their families, and one of our other tools that we have, which is the Dementia Roadmap, and how to utilize that tool in your conversations with your patients and their families. So that's what we're doing today. So let's give this a whirl and see if everything's functioning this morning with the world of technology. So I'm going to push out a question to you guys now that just says, have you ever given a diagnosis of dementia to a patient? I'm getting votes in, which is good. How many folks do we have here? I'm up to about 21, which seems 23, 25. Okay.
That should be about it.
Yeah. So I've got about 50-50. I have yes is 48%, and oh, nope, that just changed. Now it's 50-50 exactly. So 50% yes, 50% no, for have you ever given a diagnosis of dementia to a patient. So kind of a breadth to some people who have and haven't, which is great because I'm going to go over kind of one process. There's no explicit way, but there's a couple of ways that work better than others that we found. So as we know, primary care providers are kind of our frontline providers. They're the ones who often see our patients most often and have the best working knowledge of all the moving pieces that happen with a patient and their all aspects of their health. However, we know statistically that less than half of patients with dementia actually have a diagnosis in their medical record, which creates problems when it comes to all kinds of things, but referrals, other patients or other providers looking at records, they're just unaware that this is even going on, and so it's not on their radar as a concern. It can kind of throw off other aspects of their medical care. So some of the commonly reported barriers for giving a diagnosis, these are probably the top 4, which involve just a limited appointment time, especially in that 15 to 20 minute patient interval that is common, are screening tools and how good or not good they are. Another thing that comes up is this worry that we're going to cause more distress by giving this kind of a diagnosis, either to the patient or to the family. And then the broad statement that, well, there's nothing that we can do about it. So why bother? And I'm going to tell you a little bit about how at least a couple of these are completely inaccurate. In terms of diagnosing, diagnosis will increase depression, anxiety, suicidal ideation, any of these things in our patients. We actually have data that says it doesn't. So this is one of my favorite studies to point to, but it's been replicated. This is the original. So 90 people with dementia and their care partners, we measured, or they measured aspects of depression and anxiety before and after they were given a diagnosis of dementia. There weren't any significant changes in those levels, and actually many actually reported relief or decreased anxiety. Just knowing or having some sort of a label to put on something was somehow helped with reducing the amount of stress or worry or anxiety around what is going on. The other one that we battle all the time with Memory and Brain Wellness Center is, well, there's nothing that can be done about it. So why do I care? Why do you need to tell me this really bad news? We know that in mild cognitive impairment, we have tons of research that has now come out, especially in the realm of exercise. 3 to 4 days a week, what we call moderate levels of exercise. I put that in the range. People always ask, what is that? That's the point where if I'm going for a fast walk or a slow jog, I can still sort of hold on to a conversation with the person that's jogging with me, but it's not easy for me to hold a conversation. I'm a little bit winded, or I have to take a little bit of a break to stop and catch my breath before holding a conversation. So it's in that realm. If you're not somebody who's using fancy fitness watches and things like that. Diet wise, the MIND diet, which is a spin-off of the Mediterranean diet, or just the Mediterranean diet, are the two that come up again and again when it comes to promoting brain health in aging. The DASH diet for some of our folks as well, which I'm sure most of you are familiar with too. And then just general things of maintaining emotional wellness, stress reduction, meditation, things in terms of reducing the amount of stress and emotional intensity can also be beneficial. When it comes to people really wanting to know, they do. And this is something that comes up a lot with my patients. They come in and they say, I just want to know what's wrong. Tell me what is wrong. And that's what the literature has found as well. So the majority of people are in fact wanting to know what this process is so that they can either cope with it, find alternative strategies to things that they're doing, get treatment if it's an option, and just have a better idea of prognosis and what to expect in the next 1 to 5, 10 years from now. So when it comes to diagnosis, the DAC, the Dementia Action Collaborative, we put out a handful of tools. This is one of my favorites to mention to providers, geriatricians, primary care, even neurologists. It's available online, and my understanding is you'll get an email later and it'll have the links and also PDF copies of these tools as well. So you can print them off whenever you like. I really like this one in particular. It's a flow chart that helps you work through what should I do with this patient who's having memory problems. So starting off with if they're coming in for their annual wellness visits, and which incorporates some sort of a cognitive screening, mini-cog, MOCA, SLUMS, 3-MSE, any of those types of tools, and then kind of walks you through it. So if that screening is normal, okay, we'll just follow up on the cognitive side in a year or so. If it's a little bit abnormal, where do I go to next? Well, we could do more cognitive assessment, refer out for neuropsych, et cetera, et cetera. So it walks you through some of the components in that first part. The other parts of this tool involve kind of two nice one-pagers on things to consider for dementia workup, including our common diagnostic tests, some of the diagnoses and the specifics between our common forms of dementia, Alzheimer's disease, Lewy body, frontotemporal dementia, and vascular. So it gives you kind of all that good information in a very tight format. And then considerations when you're working with a patient with more of a chronic, has already been diagnosed and now you're seeing them again, working with them and managing various symptoms and recommendations for things like safety, medications, when to seek out more counseling, social work, things like that. So this is a really great tool that is available. I recommend that you can download it online, and has good resources as well for some of our folks, and it makes reference to the Dementia Roadmap, which I'll be talking about here in a second. So I'm going to shift gears. So that's my little spiel on some of the available tools for diagnosis and cognitive impairment identification. So now I'm curious, I'm going to shift gears more into giving an actual diagnosis of dementia. And so I'm putting this on you guys and asking you, so if you or a loved one was just diagnosed with early onset Alzheimer's disease, what is one word to describe how you feel? So I want you to put yourself in the shoes of the patient or the family member.
That's really cool.
Is it popping up? Good.
Yeah, the word cloud.
The word cloud?
Yeah.
Good. Okay, so you guys should be able to see kind of if everything is working right, you should be able to see the word cloud that's popping up, right? And one of the main, if I'm not mistaken, one of the main words that's popping up, right, is kind of scared or afraid, right? There's a fear component to this. And so that's probably the most common one that I also hear as well, which is just kind of, I'm scared, I'm sad, I don't know what's going to happen, and overwhelmed is another one that's popping up, and that's also something that I hear very often too. So there's a model that I really like. Is anyone, just kind of by raise of hands or flapping of hands, familiar with the spikes model? I see a couple flapping hands. Okay, so a couple. So I really like this model. It came out of oncology, actually is where it started for giving patients diagnosis of cancer. And I really find it incredibly useful for our population as well. So SPIKE stands for setting, perception, invitation, knowledge, empathy, and then summary or strategy, however you want to think of it. It's a very nice model to think through, especially as you are trying to prepare and think of how am I going to talk to this patient about what we think is going on, what their diagnosis is, and what the prognosis is. So I'll walk through it with you. The paper is actually not too long. That's the original paper that was a demonstration in oncology, if you're curious. And it's a good one to reference, and it's not very dense, which is also nice. So for setting, thinking about not having, right, you don't want to have this be in a very chaotic room or have it where, you know, your people are passing by all the time. This is a tough conversation to have, and be mindful of where you might want to receive difficult news. Might not be in, you know, a room where tons of people are passing by, it's loud, things like that. So be a little bit mindful of that. We can only do so much in certain situations, but managing time constraints and interruptions. This is not a conversation to be done in 5 minutes. So if you know that you're crammed for time and, you know, you're already backed up, you know, 3 patients long, that maybe this isn't the time to drop a huge bomb like this. We need a little bit more time to work through it. We're going to have a lot of questions, or at least a lot of silence. One of the keys that I like to remind folks of is this idea of before you tell, ask. So what have you, always start off with a question of understanding where they're coming from. What have you been told about this appointment? Why do why are you here today? What's your understanding of the MRI that you recently did or the cognitive testing that you just did? Has anyone talked to you about this before? Now, whether or not it may be a component that because they have memory loss, they either might not remember that they have been told, or they just do not know. And either way, you're still working from the same foundation or platform. It's at this point, it's kind of irrelevant whether or not they have been told in the past if they don't remember that right now. So also ask patients, but also ask their family members, so you gotta have an idea of who's coming from what page. You know, his daughter, the daughter and power of attorney knows everything that's going on, and she can talk about this without any difficulty, but the patient is clueless, and get a gauge on that. Invitation, so invite the opportunity to disclose information. So how would you like me to give the results today? Some people will, the catchphrase of just tell it to me straight, doc. Some people just want you to just tell it to you. Other people want you to go through every single lab, every single finding and result of every test they've ever been given. It's a preference. And the more that you accommodate that preference, the better of a result you're going to get. So figure out what they want or what they're most willing to hear will get you far. Providing the knowledge, using plain language, avoiding all the jargon that we love to use every day. With memory impairment and cognitive issues, giving small pieces at a time and allowing for understanding and allowing them to ask questions. Generally avoiding the idea of there's nothing we can do, because what that indicates is that you know what their treatment goals are. And that might not be the case. They might not be thinking about this from a curative standpoint, which might be what you're thinking of it. They're thinking about it as, I just want to live well for as many years as I have here, or I just want to be able to be physically healthy, right? That we can do things about that. We can make sure that they're going for walks every day. So what their treatment goals and yours are or aren't might not match up. Empathy can't be trained in 5 seconds or less, but if I had to, here are some recommendations, things that you'll experience, which are similar to the words that you guys sent to me, which are, scared, afraid, overwhelmed, shocked, things like that, are all completely reasonable reactions to this kind of information. I like to allow for silence. People need to process information. I guarantee it is more awkward for you feeling that silence than it is for them. So resist that it's not about you and your discomfort of sitting in silence. This is about them and what they need. When emotion's high, we have terrible ability to process new information. So allowing that time to settle and allowing them that time to process the information is important, because if you start going and giving them more and more information, they won't be able to track it anyway. And it'll be a moot point, and you won't have been able to get all that other good information like recommendations and next steps if they're still way behind you and still worried about the first thing that you told them. I gave you a couple of phrases there. I know this isn't what you want to hear. I wish this news were better. These are all ways of engaging, of, saying that, like, in so many words, I'm sorry, this sucks. And that's okay. To be able to admit that, because that's how they're feeling as well. Summary and strategy is that moving forward piece. So taking your next steps of what do you have planned, what's the responsibility on different parts for a treatment plan, what are our resources available, and then identifying what to do next, and in particular actionable steps, things that people can do. So a tool to facilitate this conversation as well that we developed is the Dementia Roadmap, which is an actual booklet. It's a hard booklet, so it looks like this. But there's a PDF copy of it available online. I really like it because it was designed for families and caregivers. So it's written in plain language, it's accessible, it has big and bright colors. I will show you a couple of the pages in it. So this is one of the pages that just outlines the overview of kind of the spectrum of, am I just worried about my symptoms and wondering what's going on, all the way to late stage dementia. And for each of these stages or sections, we have components like this. So in this case, this is the early stage dementia section. And these are some of the common questions that people have, what you should expect in this stage, things that you can do. So remember, actionable items, things that we can do, resources that are available. And then it also will transition into very specific things like local, like the Alzheimer's Association of Washington, and various connections in the community as well. So this exists for each of those sections. So for early stage, mid stage, late stage, even that wondering and worried. So I like the action steps. I'm big on action steps and plans. And this is one section that is in there of things that either the patient or the caregiver can do, and explicitly where to go to do them, which is also what I like. It also has a couple of components in here. There are communication tips primarily written for caregivers, but it also works for providers as well. So there's just some general information about communicating with people with memory loss in this too. So there's a couple of general recommendations. So I'll leave you with a couple of things. So prepare, think about the patient, where they're coming from, who are the stakeholders in this? Is it just the patient? Is it the patient and their granddaughter who's currently living with them? Is it, the brother and sister who are the ones who are taking care of them and they're also aging? Be mindful of the other factors that are going to impact this information of a diagnosis. Identifying appropriate resources. This is from the Alzheimer's Association website, and I really appreciate this because it actually came from a survey of patients with Alzheimer's disease, and asked, what did you want to hear from a provider when they gave a diagnosis? And so this is a reflection of the things that came from that survey, which is one of talk to me, the person with dementia, directly. So you can have the patients with their family in the room, but talk to the patient directly. The other people can hear you, and they're the ones who really need to know first, and they need to know directly. Tell the truth. Don't beat around the bush too much. Be honest about what you don't know. Be willing to look things up that you don't know and come back with that information or refer out and consult with somebody else. Plain and sensitive language we talked about. We talked about early diagnosis earlier, but test early. The earlier we can, the more we can do. And then also consider people outside of your normal age range. We have plenty of folks who are diagnosed with early onset Alzheimer's in their 40s and 50s that often get overlooked because people think it's something else. You're too young to have Alzheimer's, but in a terrifying way, you are not. So there are some of the resources that I mentioned, and again, this will get sent out as well after today, but happy to take some questions from anyone and about either the tools or the process or anything.
I have a question. Over here.
Hello.
Hi. Thank you for your presentation. So one of my questions has to do with your initial slides where you had indicated that patients, for the most part, based upon surveys, want to know about their diagnosis.
Mm-hmm.
And I was just curious if, looking back at the literature and looking at the evidence that we have, is that true of other cultures?
So from a cross-cultural perspective, it's an excellent question. I don't have a clear answer of it. So I'm not sure if we at least have literature to reflect different cultural perspectives, but it's absolutely a good question. Yes, I'm reminded of go ahead.
Yeah, and along those same lines, would it be fair to say that a lot of the evidence and a lot of the qualitative data that we have from Alzheimer's dementia and how patients and families perceive and feel about it is based upon a Western perspective?
I would agree that yes, it is probably the majority of the findings that we have when it comes to certain models that we put out for delivering healthcare information or interacting with patients in this domain. The majority have been demonstrated in Western society. So whether it's the US, UK, Australia, yes, that is true.
Okay. Hi, I had a question.
Yep.
Can you hear me okay?
Yes.
Okay. Hi, I'm David Johnson from Vancouver Family Medicine program here. My question was, is there a tool that you use one over the other tools as far as diagnosing dementia in the office, slums, and then the other tools that are available out there? And if so, could you elaborate on pros and cons and why you would use one over the other?
Absolutely. So of the kind of in-clinic tools, so I'll put that into the category of things that are 10 minutes or less. I am a biggest proponent of the MoCA. I say that because it has come from a lot of established neuropsych measures, and they've taken all the pieces of some of our best measures and put them all together and put them on one page, is what they did. I'm not going to poke the bear with this, that they recently came out, as some of you or all of you may already know, about something with mandated training now for the MoCA that costs $150. This is something that we are still trying to work through here, of trying to figure out best practice going forward. It's thrown a wrench into the blanket statement that I normally say, which is go get the MoCA, it's free, download it, and go forth. The MMSE is okay, but it's not as sensitive to MCI in particular. So mild cognitive impairment doesn't pick up as well on the MMSE as it does on the MoCA. The slums is not my favorite. It'll do in a pinch, but it's not as, again, psychometrically strong in terms of its ability to distinguish normal functioning from MCI in particular. And then our shorter components like the 3MS, the mini cog, and things like that, those are all, again, they'll do in a pinch, but if you have the opportunity to get more of 10 minutes rather than 3, go more of a MoCA MMSE direction.
Great, thank you.
Yep.
Dr. Phelan, you have a question?
Barriers that you talked about. With regard to the barriers, that was a really helpful presentation. Thanks for all that information from the collaborative. I was wondering about the barrier, if there is still a barrier around, I remember reading in the qualitative literature around this, that providers were hesitant to disclose because of the labeling and risk for insurance non-coverage. Can you comment on the current status of that with regard to, like the Affordable Care Act, and supposedly people shouldn't have pre-existing conditions factoring in, but I'm not sure that's so true for things like, for example, long-term care insurance, et cetera.
Yeah, it's an excellent question, and a difficult one to address because it's a little bit two-sided. So we're seeing that it's becoming less of an issue for the reasons that you stated. So more for that concern around pre-existing condition, and more that the insurance companies are starting to appreciate it as a diagnosis that they can actually, I'd say, more work with rather than work against. That being said, sometimes on the flip side, long-term care often will, or many long-term care facilities are now even involving some sort of like pre-cognitive screening before acceptance, so that they know whether or not the folks that they're receiving for their assisted living facility, whether or not they're going to need memory care in the near future, and whether or not they have those facilities available. So it's almost becoming a requirement to have some sort of cognitive assessment, whether it's short or long, for entry into some of our assisted living facilities and long-term care. So yeah, kind of a mixed bag, but it's sounding like more and more that having the diagnosis is going to be in the record is far more helpful than harmful.
We probably have time for one more question if anyone has one. Oh, Dr. Braun, I see your hand. Hello.
Here we are. One of my astute residents had a question that if a patient presents to you saying, I have concerns about my memory, but no deficits in my IADLs, tend to suggest that they actually don't have a problem?
Yes, so the worried well, the technical definition or the difference between mild cognitive impairment and dementia is that change in IADL status. So if I'm having cognitive symptoms, but I can still go through everything, my finances, driving, managing medications, and doing everything day to day just fine, right? That's mild cognitive impairment because it's not impacting daily functioning. It's still worthwhile. So most of the time, our subjective memory complaints may lead to some sort of diagnosis of mild cognitive impairment, but not always. And if that's the case, I would just start with more of something like a MoCA screening. If things look pretty good, then again, you can kind of go down that, again, with that kind of like the cognitive assessment tool, right? So if things are looking pretty good on that screening, they're passing that pretty well. Okay, we'll talk about that in a year. And meanwhile, here's some kind of lifestyle components that you could be doing, the exercise piece, diet, managing those chronic conditions. So sleep apnea, diabetes, hypertension, hyperlipidemia, all those good modifiable things when people are good about doing all the things we tell them to do, those are things that they can work on and potentially see small improvements in. So worth checking out or at least screening for.
Good, thank you.
Yep. Thanks so much. I think we're gonna shift to our case